The oropharyngeal airway, or OPA, is a curved piece of plastic inserted into the mouth of a patient who needs assistance maintaining a patent airway. Usually these patients will be unconscious, and always they will be without a gag reflex. The shape of the OPA helps to hold the tongue away from the back of the throat. It is most commonly used with the manual airway maneuvers, such as the head tilt chin lift, and in conjunction with a bag valve mask or BVM. Oral airways are disposable and come in many different sizes for adults, children, and infants. A variety of sizes should be available in any airway or rescue kit. Oral airways should be considered in any patient who is not breathing or who is unresponsive where a gag reflex is not present. Insertion of an oral airway in a patient with a gag reflex can cause the patient to vomit, drastically increasing the chances of aspiration. It can also trigger spasms in the airway, possibly causing an airway occlusion. It will be important that the OPA is sized properly because one that is too large or too small can actually occlude the airway. If the patient starts to gag during insertion of the airway, immediately remove the OPA. Now let's discuss the specific technique of inserting an oropharyngeal airway. Take BSI precautions. Ensure that the suction equipment is operational in the event placement of an OPA causes the patient to gag and vomit. Place the patient in a supine position. If no spinal injury is suspected, the airway can be opened with a head tilt chin lift technique. If there is the possibility of a spine injury, the jaw thrust maneuver should be used. Select the proper size oral airway. The OPA can be measured two ways to ensure proper fit. The first technique is to measure from the center of the mouth to the angle of the jaw. An alternate and equally acceptable technique is to measure from the corner of the mouth to the tip of the earlobe. Open the patient's mouth using the cross-finger technique. To do this, cross the thumb and forefinger of one hand and place them on the upper and lower teeth at the corner of the patient's mouth. Spread your fingers apart to open the patient's jaws. For this part of the procedure, a training mannequin is being used. While doing the cross-finger technique, insert the airway with the curved tip pointing to the roof of the patient's mouth. Insert the airway and slide it along the roof of the mouth, past the uvula, the soft tissue hanging down in the back of the throat, or until resistance is met against the soft palate. Gently rotate the airway 180 degrees. Stop advancing when the flange rests against the patient's teeth or lips. If the airway is too long or short, remove the airway and replace it with the correct size. You may now place the mask of the BVM that you will use for ventilation over the airway adjunct you have inserted. If the patient begins to gag at any point in this procedure, remove the airway at once, following the anatomical curvature of the mouth, bringing the OPA forward and downward toward the chin. If the patient's mental status improves and a gag reflex returns, the airway should be immediately removed. This can be accomplished by grasping the flange and pulling it down towards the chin. Suction should be available during this process since patients will often vomit during removal of an OPA. Suctioning may be difficult to perform with an airway in place. The OPA may obstruct vomitus from escaping the mouth. You will likely have to remove the airway during active vomiting. Special care needs to be taken when inserting an OPA in a child or infant since the tongue is much larger and the soft tissues of the airway more susceptible to trauma in pediatric patients. In children and infants, the OPA goes straight into the mouth following the natural curvature of the oropharynx, while a tongue blade holds the proportionately larger tongue out of the way. It should not be flipped 180 degrees over the tongue because it can tear the soft palate and uvula in pediatric patients.